Ladies and gentlemen, having discussed our electrodes and our leads, in essence, our electrical cameras, we are much ready to discuss our waves in better context, because the basis of this discussion is just an interplay between the angle of orientation of the leads that we have discussed and, of course, the direction of these vectors of the various waves and how they are directed to these leads. So for P wave, simply for P wave, which we have said represents atrial depolarization, the vector of current flow for the atrial depolarization, the vector of current flow is such that it points from the right to the left and slightly inferiorly. Remember, we have said that everything starts from the sinus node. Everything starts from the sinus node, and the sinus node depolarization from the right, then the information goes to the left. So that is the orientation of the overall vector of depolarization, from the right to the left and slightly inferiorly. Because of this orientation, the angle is generally between 0 to 70 degrees. The angle of the P wave overall vector is between 0 and 70 degrees. For that matter, what it means is that any lead that then views the wave of atrial depolarization as moving toward it will then record a positive deflection. Any electrode, that is a positive electrode that has this overall vector of depolarization of the atria moving towards it will record a positive deflection for that P wave. So we have it that the left lateral and the inferior leads. Remember that the left lateral leads that include leads 1, AVL, V5 and V6. Remember, AVL is minus 30 and then lead 1 is 0 degrees. They are very close, they are within or close to the angle of orientation of the P wave that we have said is between 0 and 70 degrees. So we expect that in these leads, the P wave will be positive. And similarly, we expect that in AVF that assumes 90 degrees, it's also close enough to the 70 degrees. So we expect that the P wave will also be upright. Lead 3 lies nearly perpendicular to the vector, the direction of the overall vector for the atrial depolarization. So for that matter, we expect that we will have a biphasic, that is normally a biphasic wave, a biphasic P wave in lead 3. It is not always the case, but per the understanding we are trying to put across, that is the expectation. Lead AVR, that is the most rightward of all the leads, will rather see the current, as moving away from it, because, 0 to 70 and then minus 150 is far off. So the current is like it's moving away from it. And so we generally expect that we have a negative P wave or a negative deflection for a P wave in AVR. So that does it for the limb leads. For the horizontal plane, that is the precordial leads, the left lateral leads, V5 and V6, they will also record upright P waves because they are also around the left lateral aspect within close to the angle of 0 and 70 degrees. Lead V1 lies almost perpendicularly to the direction of flow of the P wave overall vector of depolarization. And so V1 may also be expected to record a biphasic wave. From V2 to V4, the waveform may be variable, And apart from how the waveform may look like, overall the atria are accepted to be small, are known to be small, and so the voltage that will be generated from the depolarization of the atria would also expect not be to be expected not be to be too huge, So the amplitude of the P wave that represents atrial depolarization normally may not exceed 0.25 millivolts, 0.25 millivolts in any lead at all. So because the atria are too small to generate any substantial voltage. The P wave amplitude is usually most positive in lead 2, is most positive in lead 2 and most negative in AVR, and it's again because of the same orientation. We have discussed how the angle of orientation of lead 2 to be around 60 degrees, and if we are saying that the P wave is between 0 and 70 degrees, then it's understandable why we say that in lead 2 we expect the highest amplitude of the P wave. And then of course AVR that lies very far away should record the most negative of P waves. So this image then sums up what we are trying to put across. So that lead 1, for instance, you see how the P wave is positive. AVR that lies far off on the right now has a negative deflection, and lead 3 now has a biphasic deflection because it lies perpendicular to the orientation of the P wave vector. So apart from the wave, then the PR interval will have to be discussed again. And the PR interval, we said it represents the time from atrial depolarization to the start of ventricular depolarization, and it includes that delay in the AV node. Of course, that delay is actually the PR segment, and usually the PR interval is accepted to be between 0.12 seconds to 0.2 seconds, 0.12 to 0.2. So that will be between 3 small boxes to 5 small boxes. Let's move to ventricular depolarization. That, of course, that's the QRS complex. And we all remember from the brief anatomy that we discussed that beyond the bundle of His, we have the right bundle branch and the left bundle branch. The right bundle branch, of course, moves around along the right side or right part of the interventricular septum, all the way towards the apex of the right ventricle to deliver electrical charges to that part. And then we mentioned that the left bundle branch divides further into 3 fascicles: the septal fascicle, the anterior and posterior fascicles. And the septal fascicle, that is the first branch, goes to the interventricular septum to depolarize that part, and then the anterior and then the posterior fascicles sweep along the anterior and posterior aspects of the left ventricle to deliver electrical charges to those parts. The movement of electrical information is such that the interventricular septum is first to depolarize, and the orientation of this overall vector is from the left to the right, from the left side to the right side. So what that means is that electrical activity is moving away from leads or electrodes that are more on the left side to those that are on the right side. So we usually expect that this electrical activity will show us a tiny negative deflection that we call the Q wave. That is the Q part of the QRS complex, and we expect that this Q wave will more commonly seen in the left lateral leads because the information is moving away from the left to the right. So for that matter, we are likely to see Q waves in lead 1, AVL, V5, and V6. When the Q waves are present, let's note that generally their magnitude do not or does not exceed 0.1 millivolt, and it's important to remember this fact so that we are able to recognize pathological Q waves when they show up. We will be discussing pathological Q waves sometime later. Let's also bear in mind these fascicles that we have just mentioned. Of course, they will also become important when we are discussing fascicular blocks when other bundle branch blocks. All right. So the rest of the ventricle will then depolarize. That is after the interventricular septum has depolarized, and the rest of that depolarization is what is usually shown as the R wave. That is the next positive deflection beyond the Q part of the QRS. And because the left ventricle, we have said, forms a vast majority in terms of the myocardium, the angle of orientation of the overall vector of depolarization now shifts again towards the left side. So earlier it was moving from the right, it moved from the left, that is in the interventricular septum, it was from the left towards the right. Now because of the substance of the left ventricle, it shifts more towards the right side, the left side again. So what this means is that the overall vector is now moving towards leads that are placed more on the left side. That is why we expect that leads on the left lateral side, see again lead 1, AVL, V5, and V6 will record very tall R waves or R deflections because the wave of depolarization is now moving towards those leads. Overall, the orientation is such that it is between the angle of 0 and 90. Remember, we said that the P wave is directed such that it's between the angles 0 and 70. So if we are saying the QRS is the R is usually between 0 and 90, then we expect that every lead that is around, that has its angle of orientation close to this range, will also record positive deflections, and leads that are far away, that are far positioned away from between 0 and 90 will record negative QRS deflections. So in that sense, we find that V1 for instance, that overlies the right ventricle, will usually record a deep negative deflection instead of the R that is a positive deflection. Similarly, we are likely to find that in AVR, whereas lead 1, AVL, V5, and V6 will rather have more dominant positive deflections. With respect to V3 and V4, sometimes they are considered as a transition zone, and usually one of these leads actually record a biphasic wave, so that the R wave and the S wave, that is the positive and negative deflections that both exist, are almost equal in terms of amplitude or voltage. So what we have discussed, we realize that we have tried to say that from V1 to V2, V3, V4, all the way to V6, we will be moving from a more negative deflection to gradually more positive deflections till we hit the most positive deflection in terms of the QRS complex. and this progression is what we call the R wave progression. And later, the significance of this progression will be discussed further. Ladies and gentlemen, one important thing we haven't mentioned or we forgot to put across is the fact that because of how these waves are supposed to be oriented, when the electrodes are turned, then there should be a way to be able to determine whether the ECG we are looking at is actually a true reflection, or there may have been an error in terms of the placement of the leads. Remember, we mentioned that for the limb leads, for instance, if you were to switch from the right arm to the left arm, then everything will be reversed in a horizontal fashion, that is 180 degrees reverse. And a way probably to be able to identify some of this error may be when we see that maybe in AVR, we rather will be having more dominant R wave as opposed to the more dominant S wave that we should expect. Another way probably to find out that is when we see that in lead 1, all the waves, that is P wave, QRS, T wave, will become inverted. So an appreciation of how we expect these various waves to appear is important, so that we will be able to put our interpretations into context before we start going to town with very, very, very wild differentials. There may be a few other QRS morphologies of interest. Most often we may see one positive deflection for the QRS, but sometimes there's another positive deflection, and when there's a second positive deflection, that is called an R prime. Sometimes you may only see one negative deflection, just one negative deflection, and that's all you see for the whole complex. In that case, we call that wave a QS complex. And in this image, we realize that we have a few other morphologies. So we see the normal QRS complex there with all the three parts, the Q, the R, and the S. Then we see the RS prime in the image where we have one positive deflection. Then just when it is moving down, then we have another positive deflection shooting up. So that is the RSR prime morphology of the QRS complex. Then we notice the QS that we talked about, that is just a single negative deflection, nothing else. Then we can also have just a single positive deflection, no preceding Q, no succeeding S. So that single positive deflection is called an R wave. Ladies and gentlemen, no matter how the QRS complex looks, it is generally accepted that the duration is between 0.06 to 0.1, 0.06 to 0.1 seconds. Some texts may extend it to 0.12, but generally that is what is accepted. Some of these intervals we have mentioned, we have to keep in mind so that we'll be able to identify when there are increases in these durations. Now, our last wave of interest is the T wave that represents ventricular repolarization. And it's important to put across that although ventricular depolarization is a more passive phenomenon in terms of cellular energy consumption, when we talk about ventricular repolarization, it's a more energy involving procedure. Remember we said that for the pumps that exist within the cell membrane during repolarization, they actually actively pump these ions back in their respective proportions. So it involves a whole lot of cellular energy as compared to the process of ventricular depolarization. For that matter, the T wave is more susceptible to a host of influences: cardiac, non-cardiac, whether hormonal, neurological. A whole lot of things can influence the ventricular repolarization process, and of course that will mean that the T wave will be more variable. Generally, it is accepted that the point at which depolarization last occurred, repolarization will begin from that point. So repolarization usually begins at the last area of the heart to have been depolarized, and it moves backwards in the opposite direction to the wave of depolarization. Remember, we said that a receding wave of repolarization will lead to a positive deflection on the ECG, just like an approaching wave of depolarization. That is a wave approaching a positive electrode. For this, on this basis, then we can say that the same electrodes, that recorded a positive deflection during ventricular depolarization will also record positive deflections during ventricular repolarization. So it is normal and typical that we find positive T waves in the same leads that will have tall R waves. So we expect to have positive T waves, we say AVL1, lead 5, V5, and V6. So we see the T wave shown nicely in this diagram, and in V1 we notice that it is pointed downwards, it is negative, whereas in V6 it is upright, because V6 predominantly has a large R wave, and so we expect that the T wave will also be upright, and the opposite true for V1. Similarly, we also need to remember that the amplitude of a normal T wave is usually 1/3 to 2/3 of the corresponding R wave. Sometimes we will be discussing hyperacute waves, and then we want to find out how do we even determine. So apart from all other things to consider, we should remember that by and large the amplitude of the T wave is agreed to be around 1/3 to 2/3 the length or the amplitude of the preceding R wave. The QT interval, we said, encompasses the time all the way from ventricular depolarization to ventricular repolarization. That is all, the whole of the electrical activity, that all the electrical events that we are talking about. And the duration of the QT interval we must say that it is proportionate to the heart rate. It's proportionate to the heart rate. What we mean by this is that when the heart is beating faster, if it's beating faster, then it should repolarize more quickly, so that we'll be able to beat again. So in that case, we expect that the QT interval may be shorter. And conversely, if the heart is beating much slower, there is no urgency, for it to repolarize so quickly, and so the QT interval may then be prolonged. But by and large, it is accepted that the QT interval will constitute say 40% of the normal cardiac cycle, about 40% of the normal cardiac cycle, that is measuring from one R wave to the next R wave. But to allow for comparison of the QT intervals irrespective of the heart rates, then we discuss the corrected QT interval, and this estimates the QT interval at a standard heart rate of 60 beats per minute, so that we eliminate the issues of the differences between the heart rates. So there are several formulae that are used to calculate the corrected QT. A common one is the Bazet formula, and for that, the corrected QT is equal to the QT interval over the square root of the length of the corresponding RR waves. Of course, there are online calculators that we use for this purpose, so we may not necessarily have to chew any formulae. Generally, QTC is said to be prolonged if it is more than 440 milliseconds in men, and in women more than 460 milliseconds. And when the QT, that's the corrected QT, is less than 350 milliseconds, it is described as being abnormally short. So on this image, we noticed what we were trying to put across, that the QT is dependent on the heart rate. So we realized that because this particular heart rate is slower, the QT interval appears much longer, and compared to this particular heart rate, which is much faster, the QT appears shorter. And it is in such situations that we need to remember that the QTC will help us to have a more reliable interpretation. We have succeeded in discussing our waves as we promised we would, and we were able to do this by actually discussing how important the electrodes and the leads are in terms of the electrocardiography recording. And remember that we have said that these leads are just like cameras that are positioned to record the electrical activity of the heart, and they are oriented at various angles to be able to capture as much information as possible. We have also tried to establish that by and large, the wave of depolarization or repolarization are represented as vectors that are oriented at particular direction with a particular magnitude, and depending on the direction of a particular vector and whether it is moving towards or away from a particular lead, then we expect that that wave may either be positive or negative. Our subsequent discussion will be centered on a step-by-step process. We want to be able to find out what we should consider when we are trying to read the ECG. And very, very, very soon, this more interesting part of our discussion will be introduced. Thank you so much for your audience. Thank you for staying tuned and listening. Kindly share, as we always ask of you. Share the videos with as many as will benefit from them. Our students, medical students, physician assistants, the nursing students, everybody needs to at least have a basic understanding of ECG, so that we can all work together and help our patients. Thank you again, and see you all soon.